Welcome to class. In this presentation, you will be introduced to data analytics and healthcare data. This presentation covers chapters 1 and 2 from the course textbook. There is a lot of data collected in the healthcare domain. Data is collected from diagnostic tests, medications, clinical notes, surveys, insurance companies, and many other sources. That data is used for a myriad of purposes, from driving clinical decisions for clinicians to determining the most efficient ways to deliver healthcare services. Data analysis is defined as the task of transforming, summarizing, or modeling data to allow the user to make meaningful conclusions. Data analytics supports the transition of data into information and the development of information into knowledge, which ultimately drives decision making. Clinicians use data that is collected to make conclusions about a patient. That is considered primary data analysis or primary use of data. That is, the task at hand supports the primary reason why the data was collected in the first place. Primary data analysis is what supports the decision making and care offered by clinicians. For example, when a clinician monitors changes in blood glucose in a diabetic patient, the primary reason for collecting blood glucose was for monitoring a disease. Secondary data analysis, also known as secondary use of data, is the use of data for purposes other than the primary reason. An example of secondary data analysis is when blood glucose from thousands of patients is used for determining the predictive quality of blood glucose at diagnosing diabetes. There are really two major types of data: qualitative and quantitative data. Qualitative data can be categorized and summarized, but they are not naturally numeric values. Qualitative data takes on two forms: nominal and ordinal. Nominal data falls within discrete categories that don't have an order. For instance, gender or hair color would be nominal data. Ordinal data falls within discrete categories but do have an inferred order. For instance, survey responses on a Likert scale or letter grades would be ordinal data. Quantitative data are naturally numeric and take on two main forms: interval and ratio. Interval data is numeric data where the distance between two values has meaning, but multiplying those values has no meaning. For instance, temperature can take on many different values, and two temperatures can be compared. Also, a value of 0 for temperature, it does not have an interpretation. That is, a temperature of 0 degrees Celsius is cold, but that does not mean the absence of temperature. Ratio data is data where 0 has meaning and the values can be doubled or multiplied by a constant and still retain meaning. An example would be currency or length of stay. A value of 0 with currency means you don't have money, and therefore that carries some meaning. Additionally, quantitative data can be discrete or continuous. Discrete data includes a finite number of values, whereas continuous data can include any number. If you're ever having trouble determining what kind of variable your data is defined as, the following decision tree may help. For instance, let's say we have a body mass index and we wanted to determine which bucket best describes the data type. The first question is the data measured in units? Well, BMI is measured in pounds or kilograms, so yes, it does have units. So we move down in the decision tree. The next question is, can the values be doubled or halved and still be meaningful? Well, if we cut BMI in half, the value will carry a significantly different meaning. So we have to answer that question as no and move up in the decision tree. This leaves us at interval scale. Therefore, we can conclude that BMI is a quantitative variable on the interval scale. Data analysis can be broken down into several main branches: descriptive statistics, inferential statistics, exploratory data analysis, predictive modeling, and then also auditing. Descriptive statistics describe the distribution of data. For instance, the center is a value that occurs very frequently and can be measured with the median or mean. Spread is another measure of distribution and can be described with the standard deviation or variance. If we jump over to the next branch, inferential statistics, this refers to methods with the purpose of reaching conclusions that extend beyond the immediate data alone. Typically, we use a sample to estimate what would happen in a population. With inferential statistics, we typically adopt common statistical techniques to test hypotheses using tests such as t-tests, linear regressions, ANOVAs, and so on. Exploratory data analysis is a data mining technique where the intent is to uncover patterns in data. Graphical techniques can be adopted to uncover those patterns. For instance, box plots are a graphical way to visualize outliers in a dataset. Predictive modeling is another data mining technique where historical data used with machine learning algorithms in order to train the algorithm can predict the occurrence of a target variable. These models can be used on new datasets that have common data elements to predict future events. For instance, we may be able to use predictive modeling to predict the target variable of a heart attack by learning from historic data to find associations between data elements and heart attacks. This figure displays the relationship between each of these types of branches. You can see they are all a different type of data analysis, and they each branch off into their own discrete categories. In the second part of this lecture, we will cover data in healthcare, which is also Chapter 2 of the course textbook. A data analyst should understand the different types of data that are available for analysis. Data can originate from various sources, including the electronic health record, patient care systems, monitoring instruments, tracking registries, patient satisfaction surveys, quality indicator surveys, and just traditionally coded data. The data may come from within an organization or elsewhere. The data can also take on many different forms. There are multiple coding systems in healthcare that are used to describe data, including ICD, SNOMED, LOINC, and RxNorm. In this lecture, we're going to take an in-depth look at the different types of healthcare data and also examine the workflow of data in healthcare. The first data type we're going to discuss is diagnostic data. This is the data that is obtained when diagnoses or reasons for a visit are coded with a diagnostic classification system. Many of you are probably familiar with the International Classification of Diseases, or ICD, which is currently in the 10th revision, ICD-10, also referred to as I-10. The ICD provides a code for a specific diagnosis with partial descriptors that can provide specific information about a patient's condition. For instance, the ICD-10 code J45.0 is for predominantly allergic asthma. Understand that much of the data you will work with is still in the ICD-9 revision. Therefore, you should have a basic understanding of not only ICD-10, but also ICD-9. At some point, we will be dealing with the dilemma of how do we handle historical data that is both ICD-9 and uses both ICD-10 codes. Another important aspect of ICD is the implementation of the Inpatient Prospective Payment System, otherwise known as IPPS, which uses a two-code groupings to organize data and process payments. ICD-9-CM and ICD-10-CM data is used to compute diagnosis-related groups, otherwise known as DRGs, and this is for inpatient discharges. Each DRG falls within a larger grouping known as Major Diagnostic Category, or MDC. MDCs group similar DRGs together, but neither are coded. They're computed using a DRG grouper program, which is based on patient demographic data and the coded ICD data that has been assigned to that inpatient case. Procedural data is obtained when procedures are coded using a procedural classification system. ICD-10-CM contains some procedural coding on hospital inpatients. Outpatients services and Medicare Part B services are coded with current procedural terminology, or CPT. The Centers for Medicare and Medicaid Services has a coding system that supplements CPT called Healthcare Common Procedure Coding System, otherwise known as HCPCS, which we use with Medicare beneficiaries in codes for drugs and supplies. Finally, Outpatient Prospective Payment System, the OPPS, groups CPT or HCPCS codes to an outpatient case using what's known as the Ambulatory Payment Classification, or APCs. Procedural data is often utilized for determining the intensity of care delivery. For instance, relative value units, or RVUs, are assigned to CPT and HCPCS codes to determine Medicare fee schedule payments. RVU data exists for each individual CPT in HCPCS. Pharmacy data, or drug data, can also be collected and analyzed using a coding system called National Drug Codes, or NDC. They are typically 10-digit codes that identify a unique drug product used in the U.S. for human use. The first 4 digits of the code describe the manufacturer of the drug. Digits 6 through 9 describe the drug name, and digits 10 through 11 describe the package size and type. The problem with NDC codes is how they are organized. They can either be broken into 3 segments, each having a different number of digits. So there may be an arrangement of a segment of 3 where the first segment has 4 digits, the next segment has 4 digits, and the next segment has 2 digits. Or it could have a 5-digit, 3-digit, 2-digit breakdown, or even a 5-digit, 4-digit, or 1-digit breakdown. Consequently, the same numbers in the same order can represent 2 entirely different drugs. But the series of numbers, or the way they're broken up into segments, may be different. Therefore, a code of 1, 2, 3, 4, 5, 6, 7, 8, 9, 0 may represent one drug, but 1, 2, 3, 4, 5, 6, 7, 8, 9, 0, or 1, 2, 3, 4, 5, 6, 7, 8, 9, 0 may represent entirely different drugs. Recently, CMS created an 11-digit derivative which places a 0 at the lead of the labeler code to make all codes conform to a fixed length of 5, 4, and 2 digits. The drug shown on the slide is for the antidepressant medication known as Prozac. For this drug, it was manufactured by Dista Products Company. That's the 0777 code identifies this. The drug is Prozac, or fluoxetine hydrochloride, and is an oral capsule with a dose of 20 milligrams. This is represented by the 3105. And the package includes 100 capsules, which is identified by the 02. The American Hospital Formulary Service developed the Therapeutic Classification Grouping System, which has a hierarchical arrangement for classifying drugs. The code is 6 digits, usually separated into 3 segments by a colon, but often stored as digits without the colon. Each segment provides more specific information about the drug. Your textbook provides a great example of these codes, and then also the next category of codes, RX norm. And I highly encourage you to read through that example. RX norm is a widely adopted classification system for prescription drugs and over-the-counter drugs. It was developed by the National Library of Medicine, the NLM, with the sole purpose of allowing providers to standardize the naming conventions and the different identifiers for drugs. Healthcare data that is used for analytics is often understood to be administrative data. Administrative data is data that is collected through the registration and billing process using coded data. There are 3 common sets of codes: revenue codes, place of service codes, and claims processing codes. I will go through all 3 of these in some depth. Revenue is the total of charges generated from providing services at a healthcare facility. A revenue code is a four-digit number used to categorize charges on the Uniform Bill 04 or the UB04. This is a paper form, or the electronic version is the 837I electronic form, and it's in a standard format called the 5010 format. There's a link on the screen that provides a walkthrough for filing out the 8371 5010 version of the electronic form. The four-digit code represents a standardized code for each cost center for which a separate charge is billed. A cost center is a division or unit within a hospital, for example, radiology, emergency room, or pathology. The link under revenue codes lists all of the codes with a brief description. Place of service codes specify the entity or location where service was performed. The link on the slide provides a complete list of these codes. For example, code 26 is a military treatment facility. Claims processing codes are used when the bills are paid or if there was an error in payment. The explanation of benefit statement or remittance advice is used by payers to report reasons for lack of payment or for a claim error. The codes are broken down into three types. The first type is the claim adjustment reason codes, which are used to communicate an adjustment or provide a reason on why a payment was provided differently than what was billed. A remittance advice remark code is used to convey information about remittance processing. And the claim status codes are used in the healthcare claim status notification transaction. More information on these codes can be found in the link on the slide. CMS also has edited codes to report the reasons why hospital outpatient claims were not paid using the Outpatient Code Editor, OCE, software. More information can also be found on the link on the slide. In the next segment of this presentation, we'll cover data flow within a healthcare organization and the implications this has for decision making from data. The diagram on the slide depicts the data flow for a hospital inpatient. The orange boxes depict an action, while the blue boxes depict data that is collected due to the preceding action. Data flow for a hospital inpatient may begin differently depending on the patient. Data collection may begin when the patient is registered, if they are a direct admission from the physician's office or an outpatient department. Alternatively, data collection may begin in the emergency room if the patient arrives at the hospital, are assessed in the ER, and admitted as an inpatient. Regardless how the patient is admitted, the same demographic information is collected on all patients. This would include their name, date of birth, and other relevant identification data. Additionally, information regarding prior hospitalizations and insurance information is collected from the patient or from the family member. During an inpatient stay, patient care is delivered. Care delivery varies greatly from patient to patient. However, there are common data elements that are typically collected for each patient. For instance, as care is delivered and procedures are performed, data is typically entered by nursing staff or by the personnel performing the procedure. The diagnosis information is also entered at the time of care delivery and throughout the patient's stay. Much of this data is coded using ICD-10-CM diagnostic system. A DRG is then calculated, and that coded data, along with additional information, creates a claim form. The additional information is derived from data such as the name of the provider, the location of the services performed, and the dates of service. Also, charges for any services are recorded, such as laboratory or radiology tests or operating room procedures, which are also added to the claim form based on a fee schedule that's set up by the hospital. Once a claim form is completed, it goes through a scrubber system that identifies any reason for denial of a claim. It flags the cases for review or correction, and considering any carrier-specific edits, is corrected. And finally, the claim is sent to the insurance carrier. The insurance company reviews the claim and sends remittance advice to the hospital detailing how the claim was paid. If there is a balance on the claim, the remainder is sent to a secondary or tertiary insurance if it is present. Otherwise, the patient is responsible for paying the final bill. For hospital outpatient, data flow can begin many different ways. A patient may have an order from their physician to have a test done or a procedure performed. Typically, a patient must register with the hospital prior to arriving, where demographic information is collected along with insurance information. If a patient arrives in the ER, much of this information is collected at the hospital. Once a patient care begins, diagnosis information is typically collected and coding using ICD-10-CM. The services then are provided and coded and entered using CPT or HCPCS. This, along with additional information such as the name of the provider, the location of care, the date of service, it's used to develop a claim form. The charges for the services are added to the file based on the Charge Description Master, the CDM, which is a complete list of the services that may be provided to a patient and the charge for that service. For example, if 2 units of blood were given to the patient, the charge in the fee schedule is multiplied by 2 and listed on the claim. Additional information may be required at the time of service, such as the service was related to an occupational injury or auto accident. Collectively, this data is used for completing a claim form, which is submitted to the insurance carrier, and then any balance that is due is sent to the patient. The data flow in a physician practice is more straightforward. Data collection begins when a patient calls a clinic to make an appointment. Basic patient demographic information is collected, as well as the reason for the visit and insurance information. Patient care is delivered and data is captured. Diagnosis information is collected and coded in ICD-10-CM. Services that are provided are collected and coded in CPT or HCPCS. As the diagnosis and procedure information is entered, each service is linked to the diagnosis that supports the medical necessity for that service. Additional information, such as the name of the provider, the location of care, and the date of service, are used to form a claim form. The charges for the service are added to the file based on the amount that is set up for the CPT or HCPCS code, and any modifier that may have been assigned, and the number of services that were performed. Additional information may be required at the time of the service, for instance, if the service was related to an occupational injury or auto accident. The claim is then sent to the insurance carrier, who then pays the clinic. If there is a balance that is due, a bill is sent to the patient. Healthcare organizations maintain large databases that contain many different types of data. Data analysts should be familiar with the different data sources, as they may be required to link the sources and utilize them for benchmarking, which we will cover later on, or it may be needed for quality improvement or research, among many other reasons. The data may be stored in many different locations, such as a laboratory information system, a data repository, a data warehouse, among others. A lot of data is generated and stored internally in a healthcare organization. This includes claims data and claims forms, which are rich sources of relevant patient information. As we mentioned already, claims data is an itemized statement of healthcare services and their costs provided by the healthcare provider. Claims are submitted for reimbursement to the insurance carrier of a patient. A claim form is used for submitting the claim. These claim forms contain a lot of information, which is standardized, structured, and rich in data. You can see that the CMS 1500 claim form includes data that not only includes patient identification and insurance information, but also includes diagnostic information, date of service, charges, employer information, provider information, and if the injury was related to work. The CMS 1500 claim form is utilized for physician services, whereas the UB04 claim form is used for hospital services. Data is often stored in departmental databases. Some of these databases are listed on the slide. A health information management database contains coded data assigned to the diagnosis and procedures associated with each hospital inpatient service. Some hospitals will also have data on outpatient visits. The database works with grouper software that assigns the hospital discharges to a major diagnostic category and a DRG within that major diagnostic category. The features of these databases includes the ability to determine that all records have been coded and submitted to the patient account database, and edits that alert HIM staff of any data entry errors. A data analyst may query this database for details of the stay that are not used to generate a claim, such as the name of a surgeon that performed a procedure. A laboratory information system is a database that contains information on laboratory tests, such as orders and specimen tracking. It may include result values, report formats, and billing data. Oftentimes, the data in the database is automatically generated and entered from an automatic specimen analyzer. The coded system, known as LOINC, the Logical Observation Identifier Names and Codes, is used to code lab values and other clinical observations. They facilitate the exchange of laboratory results between facilities. Data analysts may be required to query an LIS database to retrieve data on order times, result values, professionals who perform the tests, and the combination of tests that were ordered and performed. A radiology information database is very similar to an LIS database, but contains additional information about patient scheduling, patient tracking, and staff that perform the actual exam. In a radiology exam, the patient must be present. Therefore, the appointment time and length are important for data sources for workflow analysis as well as for patient tracking. Also, not all radiologic images are successful the first time, so an analyst can determine how often repeats are done. An IRS database does not usually contain the images. However, the radiologist's reports are typically available as unstructured data. The images are stored in a picture archiving and communication system known as PACS, which may be accessible through the RIS database. Data analysts use RIS databases to retrieve data on appointment times and length, number of images taken, and professionals who perform those tests. Patient accounts databases store the accounts receivable and financial data associated with the delivery of healthcare services. Accounts receivable are typically the heart of a practice management system. Much of the billable data is stored in the patient's accounts database, including demographic information. Codes are assigned to his services and also the department charges. A data analyst would use this database for claims data, patient demographics, and claims processing codes. Finally, a clinical data repository, also known as a clinical data warehouse, is a type of database that organizes data from many different sources. It makes it readily available to users. The data may come from the different databases listed previously, or it may be entered directly from users. The data may be structured or unstructured. Structured data, or discrete data, includes data that can carry value on their own. It may include numeric values, codes, or standardized data entries such as gender. Unstructured data, however, it includes clinical notes and images, and holds challenges in using the data on their own without further processing. A data analyst will use structured data using traditional quantitative analysis, such as descriptive or inferential statistics, but unstructured data will require qualitative analyses. External data can be a very valuable resource, yet it's also difficult to find. The Centers for Medicare and Medicaid, CMS, publish a lot of publicly available data that is free to access. One such resource is called Hospital Compare, which contains a lot of information about each hospital in the U.S., including patient satisfaction, infection rates, readmission rates, and much more. Each state also has a lot of data. The data can often be found in the departments of health. For instance, the Minnesota Department of Health, MDH, publishes data on air quality, diseases, health quality, healthcare costs, and much more. The Office of the National Coordinators, ONC, also has quite a bit of data related to health IT adoption, related to meaningful use, and many other programs. The Health Cost and Utilization Project, HCUP, also holds a lot of data related to national or regional statistics on costs and use of services. For instance, you can calculate the average length of stay in different regions. However, much of this data is only available for purchase. To conclude, we know that in healthcare, there is a lot of data collected in many different formats and for many different purposes. It's important to know the type of data you're working with and its origins in order to efficiently and effectively analyze that data to create information and ultimately to create knowledge.